Diabetes is your threats to nutrition unit, 9B. It is a multi-system disease that occurs because the body is either producing insulin in an abnormal way or utilizing the insulin it produces in an abnormal way, or it's not producing insulin at all, or both, or all three. So it affects a lot of people. There's about 29 million people right now of the population that has diabetes, and about 9.3% of the population. And then there's another 1/3 of the population that doesn't even know they have it. So it's like a pre-diabetes state. So that is just huge numbers. There's all kinds of research going on, trying to see. We'll talk a little bit more about that, but a lot of stuff going on with diabetes. So people that don't know they have it, it's wreaking havoc upon their body because it damages the heart, the brain, the eyes, the kidneys, and the blood vessels all over the body before it's even discovered. Now, I think I told y'all my very first job was dialysis. I started working in a dialysis. It wasn't my favorite, but I learned a lot. But I can remember patients that were on dialysis. They'd worked their whole life, hard workers. And back then they didn't really push the going to your doctor for checkups and things like that like they do now. So now I think our preventative medicine has gotten better. But these men and women, but a lot of men were just working their whole life, and then all of a sudden they got sick. Their kidneys were gone, so they were on dialysis. But they were living with a pre-diabetic and hypertension and everything, and didn't know it because they weren't going to the doctor. So it can wreak havoc upon your body. So we're going to do a quick review of the anatomy and physiology of the pancreas. So you have 3 types of cells. They all live here in this islet of Langerhans in the pancreas. Your alpha, beta, and your delta. 3 types of cells. They're all involved with maintaining homeostasis, which is balance, right, of the blood glucose. So they all work together. So your beta cells make insulin and release it. Your alpha cells make glucagon, and your alpha cells break down stored glycogen in the liver, then release it as glucose when your blood sugar is low. It's right here. Breaks down stored glycogen in the liver, then it's released as glucose when your blood sugar is low. And then you've got your delta cells, and they just put the brakes on. They make somatostatin. So today we're going to concentrate a lot on the beta cells. We're going to talk just a little bit about the alpha cells. But if you become a diabetic nurse, then you will learn this backwards and forwards. So it's all about the alpha and the beta. We're going to break this down a little bit more. Our cell membrane is like a door, and it's closed and locked to glucose. It cannot pass through. But insulin acts like a key. It unlocks the cell membrane and swings the door open so that glucose can enter, right? So what is insulin? It's released at a basal rate, usually throughout the day, to keep homeostasis, right? Then it's released after food is ingested in high doses. So it acts like a key to unlock the door for glucose, basically. Oops, sorry. So when the cells are full of glucose, you've got the insulin that acts like a key to unlock the door for glucose. So when the cells are full of glucose, insulin acts to store the remaining glucose in the liver as glucagon.
Go back to the first picture.
Yes. The very first one.
What do you mean release basal rate to keep homeostasis? So you're saying that's the rate, or?
No, I'm saying your body just naturally to keep homeostasis, because it's an amazing, it's an amazing thing. It releases insulin just basally, so just a little bit throughout the day to keep you in homeostasis, to keep you even. So your sugars won't go down or up. Your body's made to release insulin to keep you in homeostasis.
So basal is a number, or basal?
No, it's just a term. It's just kind of letting you know that insulin's released throughout the day.
Okay.
If you're reading about it, it's on page 1120. It says insulin is a hormone produced by beta cells in the islets of Langerhans. Under normal conditions, insulin is continuously released in the bloodstream in small increments, with increased release when food is ingested. Page 1120. Okay. So, diabetes is, so what is it exactly? Well, it's disordered metabolism, right? Think Goldilocks and the Three Bears. Blood sugar's either too small, too big, or just right. When it's just right, we call that euglycemia, normal blood sugar, normal fasting level. That's what we want everybody to be in, euglycemia. If it's too low, it's hypoglycemia. If it's too high, it's hyperglycemia. It is different types. You've got your type 1, which is an autoimmune destruction of the beta cells. Type 2, the beta cells can't produce insulin, or the cell membrane can't absorb insulin. Gestational, the growing placenta releases HPL, which is your human placental lactogen, and it just causes the cells to become more resistant to insulin. The more weight the mother gains, the more pronounced this effect is. So that's why they say don't gain too much weight when you're pregnant, because you could get gestational diabetes. Usually, if you do have gestational, once you're finished with the pregnancy and all, you go back to not having diabetes, but you can have it during pregnancy, and it's called gestational.
You're at risk.
Yes, you're at risk for type 2. Yep. if you have it during pregnancy. So what exactly is diabetes? Well, carbohydrates are our main source of glucose, right? And it's a preferred source of our body for energy. Our fuel. So, glucogenesis occurs when fats and proteins are converted into glucose, and then you get some ketones in your blood, which can lead to metabolic acidosis. So fats and protein can be converted into glucose, and that process is called glucogenesis. Because remember what I said, diabetes is a problem with your insulin, right? So if you have, and carbohydrates or sugar is our main source of fuel, and you don't have the right amount of insulin or the cells aren't accepting it, then your body will automatically perform glucogenesis, and it'll start converting fats and proteins into glucose, you'll start passing ketones through your urine. Ketones are produced from burning fats. They have a negative charge, but the body likes to keep our pH how? How does the body like to keep our pH? Back to our fluid and electrolyte lecture.
7.35 to 7.45.
Right. So if there's a narrow range there. So if you have this presence of a lot of ketones in the blood, eventually this will lead to metabolic acidosis. For a diabetic. Because why? They have inadequate insulin, right? And what does insulin do? Right. So what are some different types of diabetes? Pre-diabetes, we talked about a little bit about that, but we're going to talk more about it. Insulin dependent or type 1, non-insulin dependent, type 2, and LADA or latent autoimmune diabetes, type 1.5. And this is where they're doing a lot of research, I think, looking at like genetics and autoimmune, the body producing antibodies and things. So that is LADA. That's a fairly new term. So let's talk about pre-diabetes. Pre-diabetes are just, this is the one where people don't really know that they have it, right? The doctor's not going to do a hemoglobin A1C on everybody in the room. They're just not. If your family member had diabetes, sometimes they'll do one. Sometimes if they think you're at risk, they'll do one. I have a friend, he's Hispanic, and his doctor just, he had gained some weight, so his doctor did one. And it wasn't even that much weight, but he had gained a little weight. So his doctor did a hemoglobin A1C on him. And it wasn't outrageous, but it was elevated. And so he decided, the doctor told him that if he would lose some weight, and he would do some diet and exercise, and cut back on his drinking or alcohol, then he wouldn't have to go on medication. So he did all of that. And his hemoglobin A1C came down really low, like 6, I think, or 5 something. So, so he was pre-diabetic, basically. But he did everything he was supposed to do, and his numbers came down. And the problem is, not with him, but I mean, maybe with him, I haven't really kept up with it. But it's hard for people to be that restrictive every single day of their life, you know? Especially if your culture is, to drink, to have drinks with dinner and things like that. It's really hard to just make a lifestyle out of basically eating low carb if you don't really, if you're just pre-diabetic. So I think that's why a lot of people, I think this is why this pre-diabetes is such a phenomenon, is because people have trouble living so restrictively. But if someone does and they get really serious about it, they can basically not have to go on medicine and not have to go on shots. But if you don't do anything, most likely you're going to become diabetic within 10 years. And you could possibly even need, insulin. But a lot of times, they start you on depending on which type it is, but they start you on the oral. First, they start you on diet and exercise, then the oral, the OHAs, the oral hypoglycemic agents, and then insulin if needed later. So interventions are vital. So teaching, getting the patient on board, getting them invested in the plan, those things are vital for these patients. So let's talk about insulin dependent. The pancreas can no longer produce insulin due to an autoimmune destruction of the beta cells. And this is often referred to as insulin-dependent diabetes. You had 2 slides in your slides that were the same, so I deleted the second one, but they were the same. So I don't know what happened there, but so this one's got everything on it that the other one has on it too at the bottom here. So this is often can be called juvenile onset. They've linked it to certain types of your HLAs, your tissue antigens. And then another possible factor is a viral infection, where the virus destroyed your cell's ability to uptake insulin. A lot of times these patients are less than 30 years old. They have minimal or absent insulin. Basically, the beta cells are destroyed. They're not making insulin. So that's why they need it. They usually need it. They need it injected to them, right? They need the shots. But even with these patients, diet and activity management is critical. And you will see often that they'll have vascular and neurological complications. So the type 1 can be pretty serious because what does sugar do to the vessel? It destroys it, right? If it's just left, if the sugar is just left in the vessel, there's no insulin to take it up and to take it out. So if a vessel is exposed to high levels of blood sugar, it can become damaged within 15 minutes. And so we're going to talk a little bit more about it, but you get these microvascular damages, right? You get a little damage to your glomerulus. You get a little damage to the vessel. They start having eye problems and the vision because there's tiny little vessels in our eyes, right? So then we've got non-insulin dependent. This often is sometimes called type 2 or adult onset, where they have some insulin being produced. They have a high genetic predisposition. What does that mean? What is a high genetic predisposition? It runs in the family. So there's some genetics passed down. What about as far as ethnicity? Spanish, Native American, African American. So all of these, there's a higher risk in older adults as well. Everybody. So usually the age is greater than 35. just because it's adult onset, right? And it's decreased or ineffective insulin. We've already established that. And there's a lot of times they're obese. Not always, but sometimes their nutritional status is obese. Diet control is possible. And a lot of times they'll start these patients off with OHAs, or your oral hypoglycemic agents. So who can think of some of those? Metformin, glyburide, those oral type medicines.
You said hypoglycemic agents?
Yeah, that's what they call them. All right, so your LATA, or your latent autoimmune, that is your, sometimes called type 1.5. They're estimated 15 to 20% of type 2 have this autoantibody. They have little to no insulin resistance. And insulin resistance is just when your cells, in your muscles, your fat, and your liver start resisting or ignoring the insulin signal. And what does insulin do? It grabs the glucose out of the bloodstream, right? And puts it in our cells. So these patients, for whatever reason, they have some insulin resistance, and sometimes they have little or no insulin resistance. So that's why a lot of times treatment with those oral agents can cause loss of beta cell function. So you have to be real careful with these, and they definitely need to see an endocrinologist. They'll do testing to see if they have this autoantibody. The best way usually they treat is insulin, because it shows signs of preserving beta cell function. It's not always good to start these with the orals, because it's been shown in the studies to cause loss of beta cell function completely. Huh? Just this type. This auto antibody type, because of the antibodies. They're often not overweight. So these people are not overweight. So these people, they'll monitor them. They will definitely do some diet, the way they eat, control it that way, and then they may eventually have to go on insulin. They have a really tailored approach to their diabetes, to their problem. Signs and symptoms of diabetes. Well, we've got your 3 P's, right? Polyuria, polyphagia, polydipsia. What is polyphagia? Excessive hunger. Why do you think they're so hungry? Right. Their cells are starving, aren't they? They're malnourished, so they are starving. The body is starving at the cellular level. So polyphagia. What's polyuria? They're peeing a lot, right? The water's pulled away to make all that urine, leaves the body dehydrated. And it activates the what? ADH, which makes you extremely thirsty. And then polydipsia. Right. Extreme, which causes polydipsia, extreme thirst. What about weight loss? Y'all seen somebody that has some weight loss? What do you think that's caused from? The ketones, right? The body's basically using fat and proteins of the body as energy. So you'll see muscle wasting sometimes, but they'll lose some weight. What about malaise? Fatigue. They don't have any energy. Prolonged wound healing, blurred vision. And a lot of times, unless they're really alert, these things can be missed. It can be chalked up to, oh, I've been busy at work, or I'm just getting older, I probably just need glasses because I turned 40, you know? And they'll just go buy them some readers from the store. A diabetic woman can often present with reoccurring yeast infections. That could be the earliest sign. So all of these are some signs to think about. That is often symptoms of diabetes. As far as complications of diabetes, you've got your hypoglycemia, diabetic ketoacidosis, and the hyperosmolar hyperglycemic non-ketotic coma. That's a big word. A big mouthful, isn't it? So those type people, this last one, NC or whatever, they're able to produce enough insulin to prevent DKA, but not enough to prevent severe hyperglycemia.
So with a person with the hyperglycemia.
So you just want to make sure they have a snack. Bedtime snack reduces these problems, your Somogyi effect and your Dawn syndrome. So hypoglycemia, why does it happen? Well, you have more insulin than glucose in the blood at this point. That's why if they take their insulin and then they don't eat. So when you're in the hospital, what do? We make sure they have their tray, right? We want to make sure they're eating before we give them their insulin. There's a reason behind that. Because you don't want them to bottom out. So it's always important that when you, before you give them their insulin, that they have their tray. Right. Because it takes some time to get there. Sometimes interaction with meds can cause it. Variable absorption of insulin. Alcohol intake can cause some hypoglycemia. And then exercise without carbs can cause it. My father-in-law was a type 2 diabetic, but he was older, so he took insulin. He ended up having to take insulin. And he owned a business. And he would take his insulin in the morning, same dose every day. And then occasionally, they'd have a machine breakdown, and he'd get out there and he'd work on it. So he'd use up a lot of, whatever he ate for breakfast, he'd use it up. So then what would happen? He'd bottom out, right? So then he'd have to eat him a honey bun. I thought that was planned. And that didn't happen all the time, but if he did some extra strenuous whatever, then sometimes he would bottom out. So you got to make sure that your patient knows this kind of thing, that when they exercise or when they change up something, sometimes they need to provide them, make sure they have a snack with them. So those are some So what is the treatment? Well, usually they give you a little juice, not necessarily a honey bun. That's not the best treatment. Sometimes 5 to 7 jelly beans. I've never really heard that before, but hey, it works. Yeah. The hospital, a lot of times they have these tablets, or they have the gel they can take. What does ATI have?
I swear it's something about the little caramel jelly bean or something.
Oh,
No, not the jelly bean. Serious.
a little candy. So anyway, 15 grams of carbohydrate. That's kind of what the thing is. So you want to treat the blood sugar, and then you want to take it again in 15 minutes. So you got like a 15-15 rule. So you wait 15 minutes and then check it again. And then you want to follow up with a more slowly absorbed carbohydrate, such as a sandwich, peanut butter and crackers, milk. Those are all good ways to make sure that they don't have rebound, right? And then you want to retest it again in 15 minutes. So that's kind of the treatment as far as hypoglycemia. Now, when we get to diabetic ketoacidosis, this is a life-threatening acidosis, right? It's a lack of insulin that can cause it. Say your patient ran out of insulin, or say they've been sick. Yeah, insulin's very expensive. I saw on the news, I forget what state, but one of the states capped insulin. They put a cap on it. I thought that was great. But not Florida. So, it's life-threatening. The glucose is usually greater than 250. Most of the time it's like 600 or 700. Now, I'm seeing it at 400 too. And then your treatment is IV insulin, hydration, electrolyte replacement, that kind of thing. A lot of times their breath will smell fruity because of the ketones, right? They'll have tachycardia, hypotension, their sugar will be high, and thirsty, dehydrated. And then the Kussmaul respiration. So y'all know why that is. They're acidotic. So what's happening? Your respiratory compensates first, right? So your respiratory is trying to have you blow off that acid. Okay? So Kussmaul respirations. What is Kussmaul's? Increased rate and depth at the body's attempt to blow off CO2. That's important to know. Kussmaul's respirations, increased rate and depth at your body's attempt to blow off CO2 or acid.
That is right there on your diary for you.
Yes. So, you know, in nursing, a lot of the times we're treating the underlying cause. So in this case, what's the underlying cause? High blood sugar. So we're treating it with insulin. We're treating the loss of electrolytes with replacements. So that's, think about it that way. What are we doing? We're treating the underlying cause. So your HHS, hyperosmolar hyperglycemic non-ketotic syndrome, it's life-threatening as well. Hyperglycemia is common with type 2 patients. And it can be gradual, 24 hours to 2 weeks. Because why? Because usually with type 2, a lot of times your body can make a little bit of insulin. So it could, if it's making insulin, then it could be gradual. You'll see an elevated serum sodium, an elevated glucose. They'll have a normal pH. But the way you treat it is IV fluids as well, insulin. Chronic. So we talked a little bit about that in the beginning. You know, when sugar sits in the vessels, what happens? Well, you got macrovascular and microvascular problems that can occur. So macro, you think bigger, right? Think body system. So stroke, heart disease, hypertension, peripheral vascular disease, foot problems. And then your micro is your diabetic eye disease, retinopathy, cataracts, renal diseases, neuropathy, because it's destroying the capillaries in the smaller vascular, right? Renal disease. So your glomerulus, right, is tiny little capillaries all throughout your kidney that filter the waste and filter water. So they'll often have renal disease. And they won't even know it, because you can live with some glomerular damage and not even know it. How do they diagnose it? How do you diagnose diabetes? Yes, I can go back. I knew someone was going to say that. All right, so finger stick blood sugar greater than equal or greater than 126 on 2 occasions. Random blood sugar equal or greater than 200, and of doing it. So treatment also carb counting. A lot of times they'll let them have like 15 carbs per meal. Or an exchange, exercise, and then your oral agents or insulin. But a lot of times they'll start you off with the oral if you're type 2, and then if you have to go to insulin. A lot of times, too, while you're in the hospital, they'll give you insulin, and the patients will be like, why am I getting insulin? I don't take insulin at home. Huh? Yes, a lot of times corticosteroids because of that, but also the doctors will just order like a sliding scale insulin because just the stress of being in the hospital, if they've got infection going on, just different things like that, they can monitor their insulin better and treat it better while they're in the hospital. So they'll often give them insulin as well in the hospital. Types of agents: Humalog, Novolog, regular insulin, MPH, Lente, Ultra Lente, Lantus, Byetta, Simulan. So you've got your good old vials that you draw from. You've got the pens, the Byetta pens, and things like that. So there's all kinds of injectable. They have the insulin pump now where you can wear your insulin. So there's all kinds of choices out there. As far as factors affecting insulin absorption, you want to make sure that you rotate the sites. What are you trying to prevent? Lipodystrophy, right? So basically scar tissue in different places. You want to mix, as far as mixing insulin, does everybody know how to mix insulin? So, Nancy Reagan RN. You want to draw up your air first in your MPH, then draw your air up in your regular. So, Nancy Reagan, so N, Reagan, RN, and then you draw up your regular insulin first, and then your NPH. The reason for that is, right, you don't want to contaminate your regular insulin. Why is that? With your NPH, with a lesser dose or a diluted dose. Your regular insulin is what? Fast acting. Who's going to get your regular insulin? Emergency situations, right? So you need your regular insulin to be full effect. You don't need it to be diluted or have some NPH in it. So that is why you do it that way. I have, I don't see that done very often. Usually in the hospital, we draw it up in 2 syringes. But we still teach y'all how to do it, just in case you work somewhere that requires you to mix it. But BayCare has you draw it up in 2 syringes just to prevent any error. It's a way to reduce error. You know, mix clear to cloudy. As far as oral agents, these are broken down in classes. They can be used in combination, but these are your oral agents broken down in classes. Biguanide, your sulfonylureas. I can't even pronounce them. But these are your metformins, your glycerides. Those are your oral agents. And then, of course, they even have alternative forms of insulin: inhaled, oral, buccal, nasal. So those are amazing and expensive, I'm sure. Yeah, nobody can afford these. I do want to talk to you about sick days. So you have to talk to your patient about sick days as well, because it can become difficult for the patient. They can go into ketoacidosis or the HHNK. So they have to plan in advance. They have to plan. They have to continue the meds even if not eating. So but it may have to be adjusted. They have to check their glucose every 4 hours. That's very, very, very important. You see how I'll underline that? So on the sick days, they have to check their glucose every 4 hours. And they're also checking their urine for ketones. You know, they've got those dipsticks. They can just dip their the little dipstick in their urine, so they're checking for ketones, but they're also checking their sugar every 4 hours because it can change, right? If they're not eating or they're eating less than normal, and they can utilize carbohydrates containing liquids, you know, certain shakes, whatever will help them get their carbohydrates. Stress can cause a sharp rise in blood sugar, but definitely illness. Blood sugars skyrocket when your patient's ill. If you've ever taken care of anybody in the hospital and they're in there for an infection, then their blood sugars are just all over the place. But even if they're home, this is something that we have to teach them, that they've got to monitor their blood sugars closely. So even if they're only taking them 3 times a day, if they're sick, they need to take them more often, because you're trying to prevent them coming in the hospital with ketoacidosis, right? That's what we're trying to prevent. We don't want a hospitalization just because they didn't check their blood sugar because they weren't feeling well. So you have to make sure you tell them about the sick days. I'm not going to get into this, but there's all kinds of trials out there. There's studies, but this particular study, it was a 10-year study, and it showed dramatic results advocating tight control and during pregnancy and using the insulin pump. So there's all kinds of studies out there. But this particular one proved great improvement in like retinopathy and things like that. So, if you get a chance in your spare time, you can search this study up and read about it. Patients, we have to instruct about their type of diabetes, right? Is it type 1? Is it type 2? Of course, foot care. They need to make sure they have a sick day plan. And they need to be a part of the plan. One way to get a patient compliant is to make sure that they feel a part of their plan of care, right? You want them to recognize your signs and symptoms of what? Hypoglycemia and hyperglycemia, right? They need to recognize those signs and symptoms. They need to understand how important diet and exercise is. And even like with travel, things might have to be adjusted. What kind of lab work would they need to make sure they get? A diabetic, not somebody we're trying to diagnose, but somebody that's already a diabetic. They need to get a regular A1C. What else? Blood glucose, urine. So what do you think we're checking for in their urine? Ketones, protein. Ketones is more of an immediate, quick thing, like we're checking for ketoacidosis. But what about this microvascular problem with the kidneys? What might the kidneys be releasing? Protein and albumin. Did someone say albumin? Oh. So a microalbuminuria. They check that because it helps them to know what? If there's some underlying kidney disease as well. So has the diabetes affected them so much that it's done some damage to the glomerulus, and you're spilling some proteins because your kidneys are more permeable? So microalbuminuria. And what about heart disease? What are we going to be checking for? What are these patients? What kind of blood work? Right. Cholesterol. So you need lipid panels, right? So we need lipid panels. We need so we're checking we need eye exams. They need regular eye exams. Oh, foot checks, yeah. Foot care. What else can tell us about the kidneys besides just if they're spilling ketones, protein, albumin? Creatinine, right? And GFR. So your creatinine will tell you as well. And the GFR tells you your kidney function as far as chronically, right? BUN and creatinine. BUN, but creatinine is better than BUN. BUN is blood urea nitrogen, right? But creatinine will actually tell you if there's a muscle protein breakdown, per se. We're just going to summarize. Diabetic is a systemic disease. It involves teaching at every opportunity to achieve best lifestyle for the client. We're trying to prevent long-term problems, these micro and macrovascular problems, right? Trying to prevent heart disease, prevent kidney disease. And And we have an obligation to make referrals as needed, offer support. We have to create trust with them so that they will try to be compliant and do the plan of care. Often we're working with family members as well, because you got family members taking care of people.